Hello, 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 BDO family. My name is Jade Curtis. I am the executive editor of BlackDoctor.org, and today we will be discussing 340B. So the 340B program is a relevant and timely topic, one that can often feel a little confusing or often is misunderstood. So here at BDO, we are committed to breaking down these complex issues similar to this one to make them easier to understand and act upon. So today we have two esteemed panelists who will help us unpack the current challenges facing Oregon's 340B landscape, as well as explore the potential innovative solutions. So for context, the 340B program was established over 30 years ago with the important goal of helping low-income communities access healthcare and reduce medical debt. However, over time, a lack of oversight and accountability has raised concerns about how the program is being used. So this prompted discussions about whether it's still fulfilling its original mission of helping patients first. So in Oregon, Senate Bill 533 and House Bill 2385 aims to expand a broken 340B program. At BDO, we believe state policymakers should support federal reform efforts that focus on fixing what is broken about 340B and wait to expand the program until 340B gets back on track with serving patients. So today we are joined by Pastor Mark Jackson, the Chief Operating Officer of Bridge Pomoja, and Jen Laws, the President and CEO of Community Access National Network, known as CAN. So I want to go ahead and welcome my guests. Hello, Pastor Mark.
Hello, Jay. Glad to be here.
Nice to have you. Hello, Jen Laws.
Hi, Jay. Thanks for having me.
Of course. I don't know why I said the full name, but how are you?
It's a rock star name, right?
Right, exactly. So, gentlemen, I truly appreciate your time today and your collaboration to raise the red flag on 340B. So before we dive in, can you both introduce yourselves and share what success looks like with 340B in Oregon? Pastor Mark, can we start with you?
Yeah, thanks, Jade. Again, Mark Jackson, the COO with Bridge Pomoja, based here in Portland, Oregon, really committed to the African-American community, around education and also empowerment. I think the envisioned success is to really ensure that this program gets back to its North Star to prioritize patient care. And we believe part of that success will look like ensuring that these discount resources land solely upon the patient to ensure that those healthcare access barriers are eliminated.
Wonderful. And Jen?
So I run Community Access National Network. We're a 28-year-old patient advocacy organization. We do national and state level advocacy focused on HIV, hepatitis C, and substance use disorder. And 340B plays a really kind of critical role in public health funding and making sure that patients have access to care, especially impoverished patients or marginalized or folks from marginalized communities. So I think in terms of Oregon specific, and it's true across every state, one of the ways that we would measure success for 340B is in health outcomes that benefit patients, right? Like, are we reducing health disparities? Are we increasing health equity and thus improving the lives of patients?
Absolutely. So thank you so much for sharing that. So with knowing that, what are we actually asking those state policymakers to do? Now that we see what success could look like, what are we asking our policymakers?
If I can chime in initially, Jay, I think in your opening comments, it's important, I think, for elected officials to entertain a pause, going back to Jen's point, to really look at the measurable outcome to data, to really ensure that a transparent lens is put in place, to ensure that the good intentions behind 340B are being adhered to and honored. I think it's important before we consider expansion. Let's see what success looks like as far as outcomes. And if we cannot really have that laser focused lens to really see what's under the hood, we're doing this, I think, a disservice to our most vulnerabilized population, if you will.
Absolutely. Jen, care to chime in?
I mean, I think Pastor Mark is on point in saying pause with the current actions that they're looking to do in expanding the program, especially with the lack of oversight. It's not just expansion of the program; it's prohibiting the few mechanisms of oversight that are available there. And it's not like we don't know what success in this program does look like. So in the state's AIDS drug assistance program, or in Oregon, it's Care Access, Care Assist. I apologize. We know that people living with HIV enrolled in the AIDS drug assistance program have a higher viral load suppression rate than those who aren't, even if they're in treatment. And that's one of those measurable pieces. You're stopping chains of transmission. You're improving overall health. You're improving outcomes, and the projected health path of these folks who are enrolled. And no other place do we see that, right? So, what kind of reporting mechanisms that are patient focused could we look at or encourage to be adopted? Charity care is one of them, as we see it with hospitals, but like that's just one little piece of what patients care about when it comes to interacting with the healthcare system.
Absolutely. And so as we're talking about what success looks like and seeing some of those measurable items, it's clear that in Oregon, 340B just isn't adding up, for lack of better words. And data shows that Oregon 340B hospitals have over 1,500 contracts with 340B pharmacies, and almost half of them, about 48%, have out-of-state pharmacies. So Jen, can you tell us why this is relevant, and how does this impact patients in Oregon specifically?
Well, so I think there's two things going on there. One of those things is like, where is your reinvestment in your community, right? So for these contract pharmacies, they get to peel a piece of that 340B money off the top, which is reasonable as a fee for service, right? But that should be focused in that community, right? Like, if that community is generating those dollars, then those dollars should be returned to that community in economic value. Now, when we're talking about patient access to care and getting the medications that you need, I'm not traveling across state lines to get my medications, right? And especially as I live in Louisiana, and I need to be forthright about that. When we're looking at things like climate change, if I'm being forced through a mail order pharmacy that's contracted with, my medications are rotting in the mail, right? So when we're encouraging things like contract pharmacy situations, they need to be limited to the service area of the entity in which those dollars are generated, so that you can reinvest in community, make sure patients do have that immediate and ready access to care, and they're not serving the private profit-oriented interests that are involved.
Yeah. And we already know that, patients who tend to be in these low income areas don't often have access to even, get to transportation or access to transportation to even take advantage of those opportunities. So it sounds like we're just completely taking the opportunity away from them by moving those pharmacies out of state. So, yikes. So Pastor Mark, sorry.
Can I chime in and add on to what Jen raised? I can really appreciate what he shared as far as the reinvestment in the community. To your point, Jay, I think in terms of prioritizing who's most impacted, right? Who can most benefit from this particular program. We know the medical distrust within the communities of color from the medical community, right? And to have a program such as 340B envisioned to benefit and prioritize patient care and access to care, I think that has to remain the core of this work going forward. And if there's concern that in fact that these resources are not benefiting the patient, and they're having to repurpose their time, their resources to go out of their community, right, to receive this benefit, I think there's some barriers that our elected officials have to consider, especially amongst our seniors. I think what really spearheads health equity is trusted relationships. And if you remove resources from the community, you're uprooting and creating root shock in terms of relationships. And now here we go again, having to start over again and build trust. So I think it's important for those who are making these decisions, who may be far removed from the community or the patients being most impacted, have to really kind of reimagine what this looks like in terms of their decision. And that's why it's important that we elevate. No one's disputing the intention behind 340B, But if things get off alignment or off course, we have to pause and reassess and reevaluate to ensure that the intended goal is fully achieved.
Well, kind of bouncing off of that, and that's where that reporting requirement becomes really important. But I think I'd really like to point out that in some other states where we see independent pharmacists, like those non-chain independent pharmacies, these family-focused areas where people have a lot of trust with that pharmacy, we're seeing them kind of close down left and right, in part because of 340B expansion, right? We're seeing consolidation away from communities of need and impoverished communities, rural communities, for these large chain pharmacies to fill this space at the competitive disadvantage of independent pharmacists. And we're seeing these pharmacy deserts kind of pop up as a result. So that reporting mechanism, those actionable, tangible pieces for patients in our kind of cascade of care, for lack of a better term, they're very, very real, right? And that lack of trust is a big issue. Pastor Mark, thank you for bringing that up.
Yeah, absolutely. Oh, go ahead, Pastor Mark. Were you going to say something?
No, I was just saying thank you. It's just important because I think health equity has to be prioritized, and we can't be equitable if we're excluding the individuals who are to benefit from this particular resource. And, I think within the Portland Black community, if I can speak from that lens, the level of knowledge is not robust and has really the depth we envision. So I'm not for sure what type of engagement our elected officials have done to ensure that they're hearing from the community and whatnot, to ensure that this is really getting again to the patients and whatnot. And because of the work of Rich Promoja, who worked directly with health systems across the state and servicing just a range of communities of color, it's just important that we ensure that whatever we're trying to decide upon, that we have our patients in mind, especially the historic disservice and harm that has been done. We just came out of the big global pandemic with COVID coronavirus, and people are trying to reimagine and adapt to telehealth and all these types of modes of accessing healthcare. And when you have a program that can benefit them economically and also medically, I mean, that's a win-win. So we want to make sure we uphold the integrity of this plan we envision from day one.
Absolutely. And I absolutely love that you mentioned COVID and in relation to the pharmacies and the trust that you have to build with pharmacies, because we even saw with our audience as we were trying to not encourage, but educate our audience about vaccines and going to get vaccines. They didn't even feel comfortable going to pharmacies outside of our community. We told them they didn't even feel comfortable. So if we're removing these pharmacies and we have these deserts, they may not even feel safe enough to go to these places. Safe may not be the right word, or just comfortable enough to even go to these places, whether they have access or not. So again, thank you for sharing that. And while we're on the topic, and you talked about some of the things that legislators should do, what are we actually asking them to do? Because we're saying that we shouldn't expand the program. So what should we be asking the legislators to do in the meantime, Pastor Mark?
Well, I may have kind of touched on briefly in previous conversations, but I think there should be a pause, perhaps a work group of some sorts with key stakeholders to assess the initial ideals of this program, and to, I think Jen's point, to begin to build in the infrastructures or the joists, if you will, to ensure transparency, accountability, and oversight. Right, because we can have this great grandiose vision, but in fact, if we raise the hood, right, and we see that the oil flow is not going as we intended, we may be moving, but we're polluting the air. So I think it's important for our elected officials to become active listeners, right, from those who perhaps are most impacted by this resource in terms of healthcare access. I know there's some concern in terms of how are the pharmaceutical companies benefiting economically in terms of their bottom line. We are trying to manage what we're experiencing in the new administration coming from DC. So I think we have to take a moment and slow down and really reimagine and be honest and transparent with the outcomes and whatnot, and build those systems and what that looks like and who should be at the table to ensure that we get back on course.
Absolutely. And Jen, can you, were you going to chime in?
Okay.
Sorry.
I'm all excited.
Yeah, we all are. It's okay. So Jen, when are we actually expecting, the timing of Oregon 340B legislative decision? Excuse me.
So HB 2385 is the bill in which we're seeing this move through. Now the Senate's already moved SB 533 out of committee, but we expect that to kind of be dropped as an impetus or the moving vehicle in favor of the House bill, and it moves to Senate committee. We're expecting it to be heard maybe next Tuesday because they're moving toward about the middle, closer to the end of the session. So that's a great opportunity to talk with your legislators to say, hey, maybe slow this down a little bit. Maybe look at what Minnesota did in expanding its reporting requirements associated with this. One of the things to remember, we hear a talking point from the entities involved is that the IRS already includes certain community reporting requirements, but those haven't been updated since 1969. It's been 56 years. That's not the landscape we're in right now. And speaking of one of the parts that Pastor Mark just brought up, in the HIV space, we had the Denver principles, and one of those things was nothing about us without us, right? You cannot find patient-oriented solutions without involving patients to drive that decision-making, right? So I think it's really important that folks in Oregon involved on this issue understand that regardless of the rhetoric you might be hearing from the other side of things, this is not about patient access. This is not about improving patient benefit in any way, shape, or form. And they're saying that in committee, but they're not saying that in any of the promotional materials around this bill. So that's one of those activation points that I think that we as a community could really kind of lean into.
Gotcha. And so, you mentioned that, did you say it's been 60 years since it's been reviewed?
56 years.
So, yeah. So within that time, since it hasn't been updated or reviewed, is it safe for someone to say that the healthcare system has kind of maybe taken advantage of the opportunity by not passing these savings on to the patients?
100%. I don't think there's any doubt about that. So when I talk about like the AIDS drug assistance programs or Care Assist in Oregon, there's strict reporting mechanisms involved there, right? Like it's federally funded, and then 340B reinvestment is made to make sure that you are passing along direct discount or extending access to medications. Specifically, it's antiretrovirals to prevent the spread of HIV, right? There's no other way those dollars are used within the AIDS drug assistance program, and that's really one of those things where you see a benefit, and we see this in Medicaid as well when we see MCOs or PBMs kind of get involved, where they're looking at these payment opportunities, right? There's more dollars in the system, more dollars in the system, more dollars in the system. And whether they're under the guise of a nonprofit hospital, which not all of them actually operate as nonprofits, right? That's something to keep in mind. Private interests will always make sure they get their nut, for lack of a better term. They're going to get their dollars, 100%. And it doesn't matter if the intent of the program or the public nature of the program is to benefit patients. They're going to keep their interest. So making sure that patients, like tightening these reporting standards, redirecting the program back to its original intent. And a lot of folks talk about the intent language, the statutory intent language, and that's to stretch scarce federal resources to reach more eligible patients. That's the first part of that. Now, the second part that says extend more services. But where's the measure for those things? Reaching more eligible patients should be where this starts every single time.
Definitely. Pastor, you want to chime in? I saw you nodding your head in agreement. You seem
I'm a pastor, so that's my visual amen to what Jill was just sharing. Again, we live in a capitalistic society here in America, and we understand those motivations, but we have to reconcile humanity, right? Yeah. And all that we envision to do and whatnot, because if we put profit over patient, then we lose, I think, the integrity of programming, of services, of systems, institutions, because people are at the core of what we do. And we have to prioritize this in where we are right now as a state And as a nation, people are quite concerned about their health care and the resources, and to have knowledge, awareness that there is such a program that was envisioned with them in mind and it not be fully, I think, accentuated is a tremendous missed opportunity, to say the very least. And I think as we envision this program in terms of expansion, I appreciate what Jen said. If we're talking about expansion, let's talk about expansion of access to more patients. Right?
Mhm.
How do we touch more patients to get the resources out to again remove those barriers that perpetuate health inequities and whatnot. And the health disparities are documented. It's documented by research, by data. So we're not clueless, right? But whenever we begin to prioritize profit over patient care, then we have those little holes, right? And we can't I think compromise the well-being of our community members, our Oregonians who need this type of resource for the sake of profit. I think we have to step back and really kind of recreate another iterative or chapter on how we can most be impactful with this program.
Well, and I think that's really interesting. So Senator Bill Cassidy, senior senator from Louisiana, he's in the federal government. He chairs out the Health, Education, Labor, and Pensions Committee in the Senate. It released a report last week. He had asked certain entities in this chain, kind of to respond to some questions. And one of those questions was to a hospital entity about how do you distinguish between executive compensation, like your CEO pay, and buying out physician practices around you and your charitable works, right, with your 340B dollars, to which one of those respondents said revenue is revenue. They don't make any distinction, right? And that becomes really concerning when we talk about hospital consolidation. And we've seen it everywhere. You see a hospital buy up another hospital and then start closing down access points left and right. We know where they're closing down access points, right? So this is, I would like folks to know this is not a small amount of money. We're talking about $66 billion with a B dollars in net revenue and $155 billion in total. And that's growing at a rate of about 20% or more per year. That's insane. That's an insane amount of money. Do you know how many people we could help with $66 billion? Do you know how many medications we could provide with $66 billion? Do you know how many headlines of somebody dying from not having access to their insulin or their inhaler or their EpiPen could be stopped with $66 billion?
An insane amount. I mean,
we have to sit in what he just said. We have to just sit in what Jen just said in terms of what's potentially possible with those revenue outcomes when he gets articulated. When we look at the social determinants of health within low-income communities, we look at the persistent historical physical conditions that occur that are fixable, preventable with access to health care. And we know how poverty impacts and impedes access to health care. And I think that elected officials have to listen to all of their constituents to be fully informed on decision making. When you look at that level of revenue that Jen just cited, my mind goes into lives being saved, lives being preserved, folks being more healthy to work, healthy to contribute to society. But if we pull the rug from underneath their feet and then we ask what's wrong with you, that's a contradiction. And we have to go back again and say, reconcile the humanity of this. Talking about lives, not bottom lines, but lives.
And so I guess my question is, how did we get here? I mean, if it was created as a discount program to help vulnerable patients, how did we end up here where now we're not even accessing, or the people who need the programming can't even access it? How, Jen?
That's complicated. So the expansion of the 340B program was kind of foreseen, but not necessarily in the nature of it is right now. When the Affordable Care Act was passed, right? So these hospital entities, which are the primary actors that CAN is concerned with, in part because how they're affecting federally qualified health centers and other community health centers, right? They were kind of expanded because of Medicaid expansion, right? Their qualification into 340B allowance is based on how many Medicaid patients they see. And so ideally, if you're kind of reinvesting in that, that's a good situation, right? But these hospital entities now qualified by this said, hey, if we buy out that other hospital over there, we get more patients, right? And then we can get more 340B revenue. And then we can start kind of like dominating this space because at the end of the day, whether they're nonprofit or not, they're still a business. So we kind of got off the rails there in part because there are limited reporting mechanisms. The statute itself doesn't define how the dollars and revenue should be spent or how they shouldn't be spent. So one of the things CAN has advocated for in certain states in terms of reporting, but also on the federal level is what's called allowable use. It can be wide based on a community need. But I think we can all kind of agree on what disallowed use should be, right? Not executive compensation, not consuming the competition, not consolidating the space and access to care points, making sure that you are reinvesting in serving communities. If you're going to buy a new MRI machine, I'm fine with that, right? I don't know that you need 20 of them, but I'm fine with that. If you were going to build a cancer center or a transfusion center in a rural area, that's great. But those dollars shouldn't be used to consume the existing transfusion center. So that lack of reporting, that lack of oversight, that lack of definition is a big issue, especially as we see private equity seeing 340B's lack of oversight being a great way to wedge themselves into nonprofit hospitals. And we see that with Providence very specifically in Oregon. They spent almost as much on one set of staffing services, in which there are 4, as they did on charity care. That's insane. They spent $44 million out of a multi-billion-dollar budget revenue source on charity care, and they spent almost $100 million on staffing services. And that's private staffing services. So you can't tell me that's an expense that shouldn't be better allocated, right?
Yeah. Yeah. That's much.
Well, I know you're the moderator, Jay, but I got to follow up.
You can chime in whenever you feel fit. Please do.
Well, because Jen, he's more versed in this than I am with his national reach. I'm just curious. And I know we will talk at some point about innovative approaches to this program. I'm just curious if in the statute or in the creation of this 340B, was there any conversation around these hospitals having advisory boards or councils comprised of the community to help direct and have that local level kind of build? I'm just kind of curious, was that a part of the initial conversations?
That's so it is part of the conversations. That's one of the parts where the IRS, and this isn't actually in the 340B statute, it's the IRS definition of community benefit does include board composition. But that's just one of the ways that they can do it. The other way they can do it is by having an open access ER, which by the way is also mandated by Medicare. So that's where that conflict, where it's not modern. But one of the ways is to include community members, patient members on these hospital boards. And that includes a directive to not have any of the staff that are serving the hospital that are on the board kind of making business decisions, but we don't really see that happening. And that's one of the concerns that I have. We've seen some hospitals where the board chair has a private equity company, and that conflict of interest is blaring red, right? So part of how we've approached this on what was called a request for information from this gang of 6 senators last year or the year before, I think it was the year before, was to updating the IRS code, right? Making sure that it's reflective of today's environments and some of the problems that we see, that we better define community benefit, so that there's a level of accountability held from the folks who are best equipped to do those kind of audits, right?
I appreciate that, because Jay, I just going back again, what should our legislators need to know or hear?
Mhm.
And I know coming out of the pandemic, a lot of the health systems here in Oregon were trying to uh, beef up community engagement,
Mhm.
right? We know that with Bridge for Moja, we were quite effective with the Oregon Health Authority and the governor's office during the pandemic, to your earlier comment, Jay, about vaccination access, those sorts of things, how they have these whole big, massive vaccination sites that our folks weren't going to. That was just too scary for us to go to these big old large facilities to have folks we don't know put something in our arm, right? So when clergy got engaged in partnership with our health systems, let's repurpose the venue to the community, right? Then numbers began to increase as far as people of color being vaccinated and what have you. In fact, to where our Oregon Authority cited our work as a lead contributing factor to where I think at the time last year, Oregon had the highest vaccination rate amongst Black citizens in the nation. And they directly attribute that to our work here locally and whatnot, because the community got engaged in partnership with the health system to change the narrative, right? So when we hear this IRS statute and whatnot, and really defining community benefit, these health systems are trying to diversify their boards, create strategies to be engaged in the community to save lives, right? And this right here is just another, I think, opportunity to beef up those collaborative efforts, center community voice to ensure community benefit, right? To follow the money. Just like we had those dashboards and how many folk were, had the virus in this county, that county, is no different economically. Let's just be real.
Well, and Pastor Mark, I think you're on to something there, and I hadn't even thought about it. So I appreciate you inspiring somebody, cheering me on later. I'm going to have to credit you for it. I think state legislators could look at better, tighter requirements for their hospitals, not just in reporting, but in the composition of their boards and who's driving the decisions there, right? Yes, you should have some business influence, but if you're there to serve the community should be making the vast majority of that decision with advisory from business, right?
Totally agree. Completely agree. You guys jumped ahead. I was going to ask you another question about solutions, but you guys already handed them out. I think that's amazing. And so I guess I know we talked about what success could look like, but I kind of want to dive into the future a little bit and talk about, what should 340B look like in the future? Should we start seeing success? What does the future of 340B look like? Either one of you. This is for both of you this time.
I think a truly successful 340B program, we've kind of talked about that, right? Like there's measurable outcomes. There's a piece where community knows what this program is instead of having to take somebody who's been doing this for 30 years or work in the back end of the legislator to be able to understand it, right? So kind of simplifying. I think there are ways to simplify things, but I also think there's ways to just kind of constrain some of the, what we call it, margin motivation versus mission motivation that we might see involved in this program. So we've looked at a variety of solutions on a federal level, and part of what I really like, this is hard, right? Federal, if anybody paying attention to what's going on the Hill, it ain't a lot of anything other than a mess, right? But I do think that there's some effort. I expect that we're going to see some federal reform come through, including a prohibition of something called spread pricing, where an entity kind of marks up the cost of a Medicaid drug and then tries to pass it through as a 340B claim, kind of taking some of those dollars out of the Medicaid system. So we expect to see some kind of reform on that. It's one of the things where we think Medicaid should be well supported, and 340B shouldn't be taken away from that, right? I think that we're going to see some constraints in reporting, like how are you serving your community a little bit better than what we see right now. I hope that we see some prohibition on spending money, 340B revenue, on executive compensation. And I think to kind of address something else that was kind of brought up, and this kind of speaks to all of the effort for reform that we're seeing right now, is that there's an interest from from pharmaceutical manufacturers to say, hey, where are these dollars going? And I think that's fair, right? So when we make a donation somewhere, we want to make sure that we're serving the need in which that was advertised to us, right? We don't want to see that going to somebody else's, like some padding or buying a new building that's not actually doing the thing that we want to see, right? And we saw this with the American Red Cross many years ago, especially around building homes in Haiti after the earthquake, where more than 25% of the dollars were going toward administrative fees and things like that. That's just obscene. So I think that instead of trying to frame this about who makes what money outside of patient interest, right, are these dollars going where they should be going? Mm-hmm. Are they being used for charitable purposes? Are you serving communities of need? Are you improving health outcomes? Like I can't emphasize that enough, in part because the AIDS Drug Assistance Program is so effective at using these dollars and proving those positive health outcomes for folks that are in dire straits, right? So.
Yeah, I couldn't agree more. I just I get back again to a future that involves a community that prioritizes patient care. I don't know the proper language for the federal sanctions when it comes to our banking institutions, but we know in terms of the priorities around Community Reinvestment Act and so forth, and the important around corporate social responsibility, right, to ensure that they play a lead role in the health of the community they're serving or that they're benefiting from in terms of deposits and whatnot. And I see it no different in terms of our health systems, our hospitals, in terms of just ensuring that they are creating space for community voice from the patient's perspective to ensure that the direction we're going with this program, they have a voice in that. You know, I guess it's so very, very important. I think earlier, Jen alluded to just the oversight and reporting guidance and directives. These things make up a successful future with this program. And we can't continue down this path if we're not adopting lessons learned, right? And you cannot learn if you're not being transparent and having the matrix in place to look at measurable outcomes and whatnot. Otherwise, we're all doing good. Life is great, you know. So I think that level of transparency embedded in the future of this program, I think, provides a promising horizon.
You know, Pastor Mark, I was reading a study that was just released about historical redlining and access to HIV care, right? Like there's a map. All maps are the same. So that they overlap, right? And so when we talk about reinvestment, like 340B is an excellent opportunity to reinvest, to correct historical wrongs through expanding access to care. And it's not just redlining, it's rural areas. Like the rural hospital crisis is real. A woman in pregnancy crisis in the middle of Montana that's 4 hours away from a hospital is a dangerous situation. We got to be able to answer these things. And these dollars are here to do it. So this idea that it's just too hard or we don't have the resources for it is nonsense. We have an obligation. We have the ability and we should be doing it.
Yeah. Here. That's worthy of an amen, Jade. So
Thank you, sir. Thank you,
Mark. I already went this week, okay? But, you know, Jen, you know, as we come to a close, I know you mentioned something earlier when we were talking, and I kind of want to give you the platform to share with citizens of Oregon how they can use their voice. I'm sure after hearing this conversation, there are things that they're going to remember. There are things that are kind of going to light a fire with them and say, hey, this isn't right, you know? So is there a way that they can use their voice to be involved and to see better outcomes?
Well, I always engage with legislators. I know it might feel intimidating. I am a 5'0" trans man living in Louisiana. I promise you, I understand intimidation. So not everybody wants to hear from me. But you can target your folks, right? If you got limited time, limited opportunity, write them a letter. They read them. Their staff absolutely reads these letters. Every member of the Senate Health Committee, but also write the sponsor of the bill. Rob knows is a reasonable man, right? He believes, and I spoke to the man over this, right? Like he believes he's doing this for the right reasons. I believe he believes that. And I also think that sometimes based on our own perspective and experiences and who's in our ear, we get kind of isolated as to what we think those solutions should be. So I think the more community says this is not a solution for us, the more that has traction, right? So talk to your friends about this problem as you hear it. Talk about what you want to see from the healthcare infrastructure in your community, and talk about how this could and should be feeding that, but the lack of oversight on this is going to stop that from happening. What's important to you? Do you want reduced costs on your medications? Do you want to make sure that your community clinic stays open? Do you want to make sure that the pharmacy that you're going to is in your community? All of those things matter. What is most important to you is the thing you should be saying first. Feel confident in that, and feel confident in talking to your legislators, because your relationship with them does not end at the ballot box. It is every day, all day. That's their job.
Absolutely. Pastor Mark, no amen?
Well, I'm going to say praise the Lord. Only because the late Congressman John Lewis talked about the power of the vote. Our vote is our voice. And it's not just on election day. It's, to Jen's point, it's being consistently engaged, whether it's through an email, a phone call, or if you have the capacity, an actual visit. And I believe our elected officials and their staff are very open to hearing from their constituents, from the community. So never minimize your voice or your perspective. It does carry weight. And I just want to just underscore the importance of just staying intentionally engaged, because at the end of the day, if you don't advocate for yourself and for your family and for your community, who will? Who will? Yeah. Own your success, own your story.
Absolutely. All right. Well, unfortunately, we are running low on time, but I want to say thank you so much to our panelists. This has been an incredible discussion. You guys have shared so much insight and so much information and made it easy to understand. And I think that's what matters the most. And thank you to our audience for joining us today. I really hope that you got something out of this conversation. And as they mentioned, use your voice. It doesn't end at the ballot box. You can speak to your legislators at any time of day, anytime you want. There are websites you can log into. There are numbers that you can call. But be a participant, be active. And so again, I want to say thank you all so much for joining us, and BDO family, we look forward to seeing you soon. Bye.
You guys are out. This was great.
Are we out?